Hi, everybody. Welcome to Educating and Empowering You, our monthly program that is sponsored by the Boone County Hospital Foundation. And we're continuing to do this via WebEx, probably through 2022. So we enjoy being able to record these, send these out, and of course, you're welcome to also share them with friends and family that might also enjoy our topics. So just a quick plug for the foundation. We have a couple of events coming up. We have our trivia night is coming up this Friday. So we have room for a couple more tables if you were thinking about maybe participating in that. And we're going to be out at Seven Oaks. And then in June 11th, we have our Trestle Hustle. I don't know if you can see that, it's kind of blurry because I have the blurred out background. But we have a 5K, 10K, and then a run, bike, run event all involved in that. If none of those events sound exciting to you personally to participate in, we're always looking for volunteers. So just want to make a couple of quick plugs on our events coming up. And then really excited to have Chris Hanson here with Mid-Iowa Anesthesia and Pain Services. Mainly, obviously, we're going to be talking about pain today and the services you provide. And I know that the one question that seems to come up right now is just kind of like post-COVID, how pain has changed with like long COVID and things like that. I think would be interesting. I'm sure you have that either part of it, or if you might want to address that at some point in time. But I would be happy to turn that over to you, Chris, to divulge into your program for the day. We appreciate you being here.
Great. Thank you, Sarah. I appreciate being here as well. So for those of you who may not know me, my name is Chris Hanson. I have been providing pain services here at Boone County Hospital since about 2014. Finished my fellowship through Hamline University in February of 2014, and started doing pain clinic work here shortly afterwards. Program itself has blossomed. We have another provider here that we have brought on, Damien Basande. He's not joining us for this presentation today, but he is another anesthetist that is within the group here. He is also certified in non-surgical pain management, as am I. And so we definitely have an interest in reaching out to communities offering these services, especially to people who may not have access, that may have to travel distance in order to go to some of these other communities. We have I feel a pretty good model. We do some study as far as that goes on quality improvement, and I feel have been at least impactful in maintaining functionality for people. We have a tendency to focus on a variety of different methods in which we treat pain. And so would like to talk to you guys a little bit about that today. And yes, as Sarah had asked about COVID, COVID has had its own complexities that we've experienced with that. There is still a lot that we don't know, and I'm just being frank, that we don't know about COVID-19. The effects from a long-term standpoint that have occurred anatomically within the central nervous system effects, as well as physiologically with anything from chronic nerve-related pains to chronic muscle pains that occur. So there's still a lot going on in research for that. But just to briefly discuss the services that we offer, I guess first we need to talk about pain. So defining pain itself is important, as well as the process of treatment of pain and the services that we offer within our clinic that incorporates also other services in an interdisciplinary model at Boone County Hospital. So pain itself, the International Association for the Study of Pain described pain as an unpleasant sensory or emotional experience that we primarily associate with tissue damage, or is described in such terms as damage or both. Ultimately, what does that mean? Well, that means that pain is what you experience. We can take your blood pressure. We can monitor that. We can get a number that says, yes, your blood pressure is 150/80, and perhaps we need to consider treatment for that increased blood pressure. However, what we can't do is put a monitor on you and say, oh, your pain severity is 8 out of 10, and we need to do something about that. Ultimately, why do we care about pain? Well, number one, we worry about functionality. And when we talk about functionality, we talk about meaningful participation in activities of daily living, things that are meaningful to you as a patient. Under that context, what somebody may find meaningful, such as doing things like grocery shopping, or doing chores in the yard, may be a completely different interpretation than maybe, say, somebody who has a sport that they like to participate in, such as baseball or jogging. And so we have to kind of sift through what we find as meaningful. And then the other piece to that puzzle is, do we have pain that is limiting our functional ability to do our normal maintenance and health upkeep that we need to have? Are we losing our flexibility? Are we losing our ability to stretch, exercise? Are we losing significant strength? Is it imposing a risk to somebody in their normal course of daily life? Is somebody potentially falling, risking breaking bones in the pain that they're experiencing and the deconditioning that is subsequent to that pain? And so it's important to address that when it becomes a safety issue for us as well. As far as pain itself, again, it is a unique experience that everybody has. Sometimes it's very obvious. Sometimes it's obvious that there's a bull that is, has his horns that is impaling a person, or a finger that has a staple that is through it. Some things are very obvious, and we can say, oh, well, the problem is the bull's horn, or the problem is the nail that is going through your finger. Those are kind of no-brainer things that are built-in safety methods that our body communicates to our brain. Take my hand off the burner. My hand hurts from the fire burning my hand. Or pull out that staple, or get off the bull. But that itself, that's the safety things. That's the message that our body tells our brains, hey, there's something going on that you, brain, need to address. You need to do something about it. And so there is some good things about pain, believe it or not, that we experience. And it's important from a safety standpoint to have that. However, that is more of the acute pain components. When it comes to chronic pain, there is a lot of complexity with chronic pain perception that we experience. And so when we're talking about chronic pain, then we're talking about all of the roles that various parts of our body play, from perception through transmission to the brain, interpretation within the brain, modulation from the brain down to where the nerves are coming into the spinal cord. And the purpose of including this slide is to basically show people, number one, pain itself, it is a very complex series of events that goes on. And there are a variety of areas where we can have um, uh, alteration in function, and hence increase or even decrease in pain perception that goes on. We have a variety of treatment therapies that we use, and it's not just simply I need a pain pill, or it's not just simply I need a shot. There are a variety of therapies that play a role in various parts of where we are having pain impulse, transduction, transmission, perception, and modulation. Um, so that brings me to another point that oftentimes people bring up with regards to opioid medication, the really evil opioids that people worry about. It's a lot more complicated than just simply saying opioids are bad. Um, Opioids are a tool. Opioids are a tool for people that have severe pain. Opioids are used in an algorithmic manner, meaning we have kind of a process that we go through to determine if indeed you would be a candidate for opioids. And so, under that context, CDC has gotten involved, the FDA has gotten involved and the DEA has gotten involved with regards to opioid prescriptive practices. Because there has been problems with it, significant problems that have occurred. We now have what many people have heard about this opioid crisis of overdoses that have occurred. And in updating the data here, actually, it's interesting going in this leap. 2018, we look at national drug overdoses. In 2021, it was over 100,000 opioid overdoses. And so several variables play into that. Interestingly enough, you had mentioned COVID, Sarah. Interestingly enough, there was a time during 2020, at least at a conference that I was at last year, there was some retrospective analysis on the amount of opioids that were prescribed to people. And part of the issue that we were faced with during the COVID crisis was trying to get people taken care of and minimizing their exposure in clinics, minimizing their exposure to hospitals. And so we ended up in some of the retrospective analysis having a increase in opioid prescription that occurred. Some of that was in trying to protect and treat some of these patients as best we could. However, that also creates an increase in access. Now, I say this, that is only one piece to a very complex problem. So there is a thought that the increased access has led to a slight increase in overdose. However, we also have increased drug use as well that has occurred, increased heroin use that is laced with substances such as fentanyl. And so with that, we have people that show positive on their post-mortem drug analysis that goes on that shows that they have fentanyl in their system. Really, they thought that they were shooting up heroin, but that was heroin that was laced with fentanyl. And so there's a certain population subset that unintentionally is overdosing, trying to use heroin. And lastly, there are people that are unintentionally overdosing that were perhaps dealing with more of a psychogenic component to their symptoms and maybe had polypharmacy on board. And we have been trying in healthcare to work through limiting some of those risk factors to to people who have sleep apnea, etc. And then when you combine that with some of the increased depressive issues that were going on during the COVID crisis, during isolation that occurred, decreased access to care, that created, I think, this situation that we were in with the increase in drug overdoses as it stands. Otherwise, there has been significant efforts moving forward through the CDC, DEA, and the FDA to try and mitigate some of these practices that have perhaps contributed in whatever manner to this opioid crisis. And in that context, one of the issues that we deal with, and it's not every patient that we receive as a referral, but there are some patients that ask, well, why is my doctor looking at other alternative options for my pain? Why can't I stay on my hydrocodone or my tramadol or my oxycodone? Why do I have to decrease use of that? And the answer is that literature has found that there are increased risks and side effects from using these medications long term, and that we need to try and mitigate and minimize the amount of them that are being used. Now, does that mean if you have cancer, you should not have access to it? No, absolutely not. Does that mean if you have some sort of an acute injury that you should not have access? No, absolutely not. Post-surgically, should you not have access? No, you should have access to it. However, when we're talking for chronic treatment of these health issues, we really need to focus on other components of treatment. And that takes time, that takes education, that takes kind of peeling away the layers, because we're very, very complex creatures. As you know, we discussed briefly earlier on, complex under the context of how our body works. And there is a variety of ways in which we can help with treatment of that. So that's why now DEA has this kind of algorithmic process, which includes incorporation of pain management clinics, where we focus on some of those educational components, focus on if there's any physical modalities of treatment. Again, deconditioning itself, not utilizing muscles, not staying stretched and having tight hamstrings. All of these things can increase pain. The analogy that I like to use with patients is suspension bridge analogy. Under that context, we have our structure, our bones, our discs, our joints. Structurally, they play a role in the suspension bridge that is our bodies. But then we also have these tension cables, these muscles. And so if there's a structural issue, these muscles will tighten up. And if they tighten up, they can be a source of pain. The classic example is if you fracture your femur, you have not only bone pain from the bone being fractured, but you also have pain from muscle contracting, spasming, trying to pull those two fractured ends together. Likewise, our bodies are unique under the context that if we have a structural issue going on, these muscles will also try and tighten up to support structural issues. Or we could have muscle dysfunction. We could have an issue with those tension cables, and then structurally, we end up having flaws within our structure. So our bodies are dependent on structure and muscle function, all playing a role in that. That includes doing things that focus on core muscle strengthening, flexibility, and endurance, working on prevention of deconditioning. And these are all physical modalities of treatment that we incorporate into that. Additionally, we look at adjunctive treatments that are supplements as well. Some people just have nutritional deficits in things like B vitamins or in magnesium. Some people are benefited by non-opioid adjunctive treatments. things that treat, say, neuropathic pain. Some people are benefited with some antidepressants or anti-seizure medications. Ironically, it does not mean that people are depressed or that they have seizures, but we know that they help out with nerve pain. Some people are benefited from psychotherapy as well. We know that if we experience pain on a chronic basis, we know that if we are on opioids on a chronic basis, some of these scoring systems that we use to identify depression are increased. We know that some of our experiences that we have can play a role in how we think about pain or sensations that we're experiencing. So oftentimes what we need to do is look at, is psychotherapy an option? Would somebody be benefited by cognitive behavioral therapy or by biofeedback, by relaxation techniques? And these are all non-pharmacologic treatment modalities that you're tapping into your body's amazing way to treat itself. We inherently have some of the most amazing tools at our disposal that we need to tap into. And there are other options that we offer here in the pain clinic as well. People think, oh, well, I'm going to go to the pain clinic and get a shot. Yes, we offer injective therapies as well, but that's only one part of that. Again, I go back to the importance of education as well in some of what people are experiencing. I think sometimes also going along with that psychotherapy component, I think fear of the unknown plays a role in how people perceive what they're experiencing from a sensation standpoint. So, how do we at Mid-Iowa Anesthesia help? We try and provide treatments to synergistically optimize your wellness. We use a multimodal therapy model, meaning it's not just a shot, it's not just a med, it's not just a supplement, it's not just exercise. We offer all of these things combined. We also have an expectation that people participate in their care as well. We need to have buy-in in that. And if people are not actively involved and invested in their health and wellness, we're only going to be so beneficial. And at some point, we're not going to be that effective in helping you with your overall wellness. And so that is a conversation that I can't tell you how many times a day that we have with people. I can't tell you how many times people say, physical therapy, oh, I can't stand physical therapy, or, oh, it doesn't help. But the reality is we know physiologically things like physical therapy help with deconditioning of muscles, help with nerve-related pain. Structurally, within our backs, we have these little side holes that nerve roots come out of that are called foramen. And we do activities like neural flossing. Well, these nerves are continuous all the way down our legs, all the way down our arms. And we do stretching exercises to floss those nerves to make sure we don't have adhesions and to make sure that there's free movement. And sometimes those nerves can wiggle into where there's just a little bit more room to help prevent some of the nerve pain that people experience. And again, I go back to the importance of some of these physical modalities of treatment that are just perhaps, I think, a little underutilized. And I think some of that is because of just a lack of understanding about the importance of keeping our bodies functioning as they are meant to be functioning. Talking a little bit more about arthritic pain. So what I will say is that joints do degenerate. We do have cartilage that does wear out and go away. We do have some options from a palliative standpoint and an injective therapy standpoint that we can offer. Some people are not a surgical candidate for their pain. Say they have a bad heart that would prevent them from getting a knee replacement done or even a hip replacement done. Some of the procedures that we offer here are actually a good thing to consider, um, such as radio frequency ablation of nerves that go to these joints. So we know anatomically where some of the nerves that go to our knee capsule or to our hip capsule are located, or our shoulder, and we can do test blocks to see if we get effectiveness and pain control with it with some local anesthetic. And if we can verify that, yes, you would be benefited with it. And when we do diagnostic blocks, the other piece to that is we are looking at pretty significant proof or evidence that that would be beneficial before we pursue doing a more invasive procedure. And a more invasive procedure would be to take a needle, and it has a non-insulated tip on it that heats up the tissue around it and coagulates the nerve, makes the proteins change their shape within within the sodium potassium channels of these nerves that we're treating, and so they can't conduct the electrolytes to send the impulse down the nerve saying that there's pain going on there. And so that is a good option, because if you short circuit that pain impulse, the brain is not going to receive data from that nerve ending saying that there's pain going on. No, it does not treat the arthritis, but it is a good palliative option that we can offer for people that are non-surgical candidates. And when we do this particular procedure, people can experience anywhere from 6 months to 2 to 3, sometimes 4 years relief with that. And we do that in not just knees, hips, shoulders. We can do it in back and neck as well. Again, though, we do have to go through a process in which we do diagnostic blocks. So this is just more exposure, if you will, to what it looks like with your knee geniculate treatment. We've seen some pretty amazing results with this, life-changing in some people's cases who are not surgical candidates. Um, Otherwise, we do offer basic treatments for osteoarthritis as well. Anything from continuing to do physical therapy. Osteoarthritis is actually responsive to activity. Our bone structures are meant to be used. We are meant to bear a load. We are meant to be stressed a little bit. We are meant to do those activities that tell our bone, hey, you know what? You need to start rebuilding yourself. You need to build back up a little bit more. If you don't put a load on your bones, they are not going to respond. Your joints are not going to respond in the way that they should. We do offer also steroid injections, viscosupplementation. If there's an indication for surgical referral, obviously we can make that as well. But these are all treatments that are available to people that we offer here. And I don't know if I'm making it clearly enough. It's important that people have a buy-in, that people participate in those wellness activities that overall are going to benefit the treatments that they're receiving. Ideally, we would not have to treat people, but we are here for that if it is needed. Um, Anti-inflammatories, that's another piece that I want to discuss briefly, especially COVID. So in light of COVID, some of the bigger risk factors were blood clots occurring with that. What I will say is this. We knew prior to COVID that there's increased risk of adverse cardiac events or vascular events in using anti-inflammatories for people after they've had a previous event. So what does that mean, all that gobbledygook? Well, if you've had a previous stroke, if you've had a previous heart attack or a previous blood clot, you probably should not be using anti-inflammatories baseline anyway, because it increases your risk of cardiovascular problems, recurrence of clot, etc. Most cardiologists will advise people that. However, you can use Tylenol up to 3 grams per day in place of anti-inflammatories. Unfortunately, Tylenol is not a superb anti-inflammatory treatment. Otherwise, we do a very thorough assessment on people. If you do not have imaging done before you come in for evaluation with us, we will order imaging. Otherwise, we also use a variety of assessment tools, not just physical exam, in order to determine what we think is your greatest contributor to your pain. Oftentimes, people have multiple pain generators. And so the other piece that may be surprising to people is that we are working through that process. There are some things that we may do and it treats one type of pain, but there's another type of pain that's going on that we may need to address at some point as well. And some of this is kind of like an onion where we're peeling away the layers and we're saying, okay, this was this problem, this was this problem, but there's still this other problem. And we do need to sort through that. And that does take a little bit of time. Um, Otherwise, just going over back pain, there's all sorts of causes of back pain that people experience. And that's part of putting together the entire physical exam that we do, as well as going through all the various diagnostic studies that are utilized with that. I spoke briefly about geniculate ablation and shoulder and hip nerve ablation. We do the same thing essentially in the back and neck. And so when we talk about facet pain or facetogenic pain, there are some small bones within our back that allow us to bend, but not too much. Small bones shown here. And those bones have nerves that go to them, which are called medial branch nerves. And we do offer radiofrequency ablation to people who need it here at Boone County Hospital. And again, same process. You have to go through diagnostic medial branch blockade before doing an ablation. Otherwise, what I will say is with your evaluation, I think it's important that if you have any challenges remembering details, I know I personally do, I think it's wise bring a spouse with you. Bring somebody that can help advocate for you. I think that's very important. I think it's very important that people have an understanding of the plan of care that is going on for them. I feel like all too often we have this tendency to speak to people and we rush and we are just hitting them with gobs of information that may be way over their head. And so I feel like it's very important to have somebody there present with you. And then otherwise, the other piece to that puzzle is we may have follow-up visits as well. And we do these follow-ups because there may be some missed symptoms that could go on. We are human. We do try and be as thorough as we can. However, sometimes patients may miss a piece of data, or we may miss a piece of data in a physical exam. And so some of this also lends to the importance of doing follow-up visits. So when we do injective therapies, it's also important. So at any rate, where I was at, talking about time for an injection, I feel like, having that kind of repetition in, making sure that we have good communication about the appropriate conditions for it. Again, we oftentimes will have issues when it comes to injective therapies where we have to make sure we have insurance that is taken care of as well. They kind of play a role in some of our care. That's just the reality of how healthcare has gone now at this time. So not everybody gets an injection if they have it in their mind that they're going to get it, or if they've been referred for an injection. Sometimes we have to do some of that legwork to make sure that we have prior authorization with insurance companies. Otherwise, when it comes to injective therapies, again, some of these injections are diagnostic and potentially therapeutic. Diagnostic under the context that we're trying to figure out, is that the pain generator where the greatest amount of pain that somebody's experiencing is coming from. So otherwise, when it comes to the services that we offer a variety of services.
We try to do these in conjunction with local primary care providers as well. Oftentimes we will receive referrals from specialists for services, but we generally still ask who your regular doctor is so we can make sure that there's good communication really in everybody that's involved in your care. We try and do a good job of making sure that everybody is carbon copied, so to speak, with our notes and findings. Otherwise, again, we look at multimodal treatment for patients, and we try and tailor our plan of care to what's going to be the most effective means to treat somebody to get the most buy-in from them. Lastly, when it comes to some of these injective services, we offer a variety of injective services. I think that are overall effective in management of a pretty robust number of pain generators that people may have. So otherwise, all that to be said, I definitely would be open to entertaining questions. If you are looking for a referral or would like an evaluation, we're located here at Boone County Hospital. You can look up on the Boone County Hospital website, Pain Clinic. Otherwise, our clinic phone number is 515-433-8760. And with that, are there any questions?
I had some questions, and hopefully maybe it'll cover. And when we were on pause, I was asking if anybody had any, and nobody spoke up. So hopefully I'll be able to maybe address a couple of things.
Sure.
You talked about a referral. So just from a typically primary care physician, is that where they typically come from?
So yes, so patients, some can be self-referred. What I would say is this, I think it's important to have communication with everybody that is involved in your care. We accept self-referrals. We accept referrals from primary care providers. We accept referrals from specialists. We receive quite a few patients from Iowa Ortho, but we have other specialists, including over at Mary Greeley, that refer patients to us to be seen and evaluated and treated. And I think it's important to make sure that we have good communication in that respect. So it's something that we will always ask, even if you're a self-referral or referral from a specialist who your regular doctor is. And we try and make sure that there's good communication with that.
So you said you added a CRNA to your staff here at Boone County Hospital. Is that, but you also have other clinics and other hospitals?
We do.
And I know we sometimes, with this being recorded, we might have people from various parts of the state. Sure. Can you talk a little bit more about that?
Sure, yeah. So Mid-Iowa Anesthesia, so we cover a variety of locations, Guthrie County Hospital and Guthrie Center, Story County Medical Center in Nevada. We also have services in St. Anthony Hospital in Carroll, Iowa, Cherokee Regional Medical Center in Cherokee, Iowa. Yeah, we cover a variety of locations. Again, it harkens back to what I mentioned earlier. We have this focus on treating people, offering services where they're at that maybe perhaps they don't have access to or would have to drive significant distance to attain.
Yeah, absolutely. Well, and I think that just the biggest thing for me that I take away from every time I hear you talk, and you and I have had conversations over the years, but I think that it's just your philosophy of practice and how you approach, working with the person's health and wellness, and really helping them see that there's maybe some alternatives to work with before they kind of go into a severe intervention route kind of thing.
Yeah. Well, and speaking likewise too, I'd mentioned physical therapy. Obviously, we're big proponents of it, but physical modalities of treatment come in a variety of forms. Could be physical therapy, could be massage therapy, it could be yoga therapy, which I happen to know somebody who does some pretty great work with yoga therapy. It could be Tai Chi. There's a variety of physical methodologies in which we can incorporate treatment. And we try and be inventive with it as well. Under that context, what I mean is not every town has an aquatic rehabilitation center, but many towns have hotels which have pools. Many towns have physical therapy departments which are able to provide a patient with good quality isometric and balance exercises they can do in the water. So these are all, just kind of thinking outside of the box, trying to meet people where they're at, looking at the services that are available to them. So
wonderful. And this is probably just like layman's not quite knowing or understanding all the lingo, but my question I wrote down was, what is polypharmacy? I don't know.
yeah, so polypharmacy. So polypharmacy just means a variety of different pharmaceutical agents. Typically, when we talk about polypharmacy from an overdose or a negative standpoint, we're looking at somebody that is on a combination of benzodiazepines, which are commonly prescribed for anxiety, but that do alter how our breathing is, especially when we sleep. Opioids, which alter our breathing while we are sleeping as well. And then there are some other medications, including some anti-seizure medications that alter how we sleep or have increased risk of adverse events with. So all of these play a role in, I think what I mentioned about polypharmacy, the risk of drug overdose. And so that's why we have to be very diligent as healthcare providers and what we're prescribing and what treatment modalities people are receiving.
So basically it just means like that it can be like a depression, like what you mentioned, the depression medication is used for something else.
Correct.
So there's multiple layers to the benefits potentially to that medication. Got it. Well, thank you. I think that covers it for me. Those were the only questions I had, and I don't know if anybody else has anything else.
And again, I apologize about the technical.
Oh, it happens to the best of us. So, well, we'll call it good for today, and thank you so much. Well, even my alarm was telling us to stop. So, thanks so much, everybody, for being here. We'll be back next month. Thank you, Chris.
Thank you.
Take care. It's okay. No.